Thank you, Scott. Good morning, everybody. Like you said, my name is Isla, and this is Julia, and we work at the Neurobehavioral Unit at the Kennedy Krieger Institute, where, as Scott said, we work with a wide range of kids who present with severe problem behavior and a wide range of developmental disabilities and genetic disorders. And we were actually just talking yesterday or Wednesday with a large group of our colleagues and realized that I think Wendy is the first with 1P36 that has come through our doors. So we are also learning along with you about this genetic disorder, but hope today can talk a little bit about some of what we know about behavioral issues with 1P36ers and also just other kids in general and how we approach treatment and assessment decisions. So our goals for today is, like I said, we're going to cover some commonly occurring behavioral issues for the 1P36 child. And of course, a lot of our literature that we base that on was initially provided by Scott. So similar disclosures there in terms of just limitations, the number of kids that this data is based on and how much room for growth there is in that research area. And then we're going to talk a little bit about the initial steps in the assessment process of behavioral problems. Review some of the commonly occurring environmental triggers to these challenging behaviors. And then we're also going to look at some various treatment options. And I'm going to give you a case example, and I'll give you one guess as to who that case is, and review some of the data of working with Wendy and her wonderful family over the last year. So like Scott mentioned in reviewing some of the literature, about 50% of individuals with 1P36 deletion present with some sort of behavior disorder or some sort of behavioral challenge. And I agree, I bet that number is a little bit low, but that's what the research is showing us so far. The most common occurring behavioral issues for kids with 1P36 include that self-injurious behavior, excessive temper tantrums, some unexplained agitation and stereotypic behavior, and then reduced social interaction. Of course, there are other potential behavioral issues that we often see at the NBU, and that can include aggressive behavior towards others, property destruction, disruptive behavior, pica, which is eating non-food items, running away, as Scott I agree with Scott, Wendy is quite good at, issues with incontinence, general non-compliance, and dangerous behaviors. Do some of these things sound familiar to you guys out there? Okay. So we're touching on, I guess, a lot of things that might be familiar for you guys. So before we kind of get into everything, I wanted to bring up some important points that are going to come up across our talk today. The first being that the answers are not quick and easy. I mean, you just heard Scott say that I've been working with them for over a year. And certainly some things made some quick progress and some things we're still working on. You know, it's not easy to find the answer for each of these kids, and it's as Callie said, every kid is an individual, and that's how we treat them. There's not one answer, one clear treatment path, just because a kid presents with self-injury that we know exactly what to do in that instance. The causes can vary greatly, and therefore the treatment approach that we take is going to vary greatly as well. And assessment takes time. We need to understand as much as possible about that specific behavior being exhibited by that specific child to understand how we want to intervene and treat that behavior. So therefore, the treatment evaluation also takes time. There are multiple steps that we're going to go through today, and it all is a long process that everyone needs to be patient and an active participant in. So what do we do? Well, it depends. Like I said, every child is an individual, and so how we approach it is going to depend on what we see when someone walks in the door. And even knowing a diagnosis of 1P36 doesn't necessarily narrow down what we're going to do. It might give us some indication. As we know, a lot of kids with 1P36 have self-injury. Do they definitely? No. We don't know that until they walk through the door. So it's going to depend on how we approach things. Generally speaking, the first steps we're going to take are to rule out any medical and physiological problems first and treat those accordingly. So Scott did a great job of reviewing a lot of the potential medical issues going on there. Other things we want to look at, if a child comes in and they engage in pica, in that eating of non-food items, we'd want to make sure, is there some sort of vitamin deficiency that's going on there that might be attributed as to why that behavior is happening, and treat that accordingly. If a child comes in and a parent is saying, they won't do anything I say, they're so non-compliant, well, one of the first questions we're going to ask is, has their hearing been tested? You know, can they hear what you're asking them to do? If that's clear, okay, well, we know some of those issues are going to have been ruled out. Now we know how to move forward. If a problem behavior you're seeing is sort of developed out of nowhere, spontaneously, or maybe it's more mild in nature, we want to rule out things like boredom. And that's something that I can talk a little bit about Wendy too, looking at is it just a lack of stimulation? Is there something, again, the quick and easy fix for certain things of adding more activities to a child's schedule, looking at your own behavior and how you're responding to it or not responding to certain behaviors, that can be maybe a quick fix or at least an initial quick fix as things keep going forward. If you've tried all of these things, that's probably a time to go seek out more appropriate behavioral services. So that brings up another question. What are appropriate behavioral services? And again, it depends. Generally speaking, our recommendation is that you find a provider who uses the theories of applied behavioral analysis to approach the treatment of problem behavior. And I should say, we focus a lot on the aspect of reducing problem behavior, but as we'll get into a little bit, but I might not say as often as I'd like, that also includes increasing appropriate and adaptive behavior. So that kind of comes into play more as we get into treatment, but that's something that if you're looking to target that specifically, problem behavior isn't a big concern for you. Providers who focus in ABA can also be looking at increasing appropriate skills as well. So what is applied behavior analysis, or ABA? It is just one approach to understanding behavior. Generally, when we talk about it being applied, it's going to look at the behavior that is of social importance to you and your family. Obviously, behavior is what we're seeing. What are people doing? And then we're analyzing that. We're identifying the relationship between the behavior and the environment. And that environment includes you guys as caregivers, siblings, teachers, all of those people that are surrounding your child. It is an evidence-based approach with over 40 years of success and has shown particular improvement for kids diagnosed with a wide range of developmental disabilities, including autism, and who have engaged in severe problem behavior. Generally speaking, the overall goal of ABA is to increase a child's independence and their involvement in their community. So just to talk a little bit more about how we think of ABA, in that it being applied, we're looking at behaviors of interest that are socially significant to you. So we're not going to tell you what the problem is. You need to come to tell us and say, my child is engaging in this behavior and it is impacting their functioning for this reason. There might be behaviors that you say, you know what, I don't care that they do that. That's fine. That is not socially impairing to them. That doesn't limit their ability to participate in the community. Great, we'll leave that alone. Let's talk about what your concerns are. So it's not about if your kid engages in self-injury, but it's mild and it doesn't bother you, then we don't need to treat it. If it's mild and it does bother you, then we do. It's what's socially significant to you and to your child. So that also does include teaching those adaptive skills, working on communication, increasing compliance. If those are areas that are impacting their ability to be independent and function in their community, then that's socially significant, that's applied, that is appropriate for ABA type services. And as I've said, and I'm going to keep saying, we approach each person as an individual and we have to take their likes and dislikes into account. I'm going to talk more about that in a little bit. Again, so the behavior part, behaviors of interest can be anything at all, depending on what you are concerned about and what you want to see growth for your child. Looking at the problem behavior, of course, but then also all of those appropriate skills, increasing communication like Scott talked about, looking at engagement with toys or general compliance. The focus here is that we want to teach kids that there are consequences for the behavior, both good and bad consequences, and that they have the ability to communicate their wants and needs in a way that is appropriate and adaptive and acceptable to you as their caregivers. So the analysis part of it is that we want to know why a behavior is occurring. It's not enough to just know that the behavior is occurring, but we want to know why. So we look at basic principles like reinforcement to help change that behavior for the better. So our goal at the NBU and in terms of general ABA practice is that we look to change the environment. And again, the environment includes you, so we may be asking you to change your behavior to support that appropriate behavior and discourage that problem behavior that you've identified as being socially significant for you. So generally speaking, we're going to work to teach children that their problem behavior no longer works, to get that why are they doing it, reduce their motivation to obtain the reinforcer, and I'm going to talk more about reinforcement in a minute, and teach them a different way to obtain that reinforcement. So again, we're wanting to know why, we want to know what, and we're going to move forward using the answers that we get from that information. So part of ABA is looking at the ABCs. And in this situation, ABCs stand for antecedent, behavior, again, the B is pretty consistent across the board, and C as the consequence. So in terms of the antecedent, we want to look at what is happening right before the problem behavior occurs. B, of course, is that behavior of interest, and then C, what happens after the behavior happens. So our example here might be that a child is presented with schoolwork. That's the antecedent. The behavior is that they then hit their teacher, and the consequence is that the teacher reprimands them. So those are our ABCs, and that's going to come into play in a little bit more as well. In addition to the ABCs, we also want to look at what is happening in the recent or distant past that may also be affecting behavior, and we call that setting events. And those can be actual events, such as the loss of a family member or a loss of a pet, or something else going on internally with the child. So if they're feeling sick, if they're hungry, if they're tired, I know that affects my behavior. If I'm tired, I may engage in more socially inappropriate behaviors myself. So we want to look at those things as well, as they're really important to consider. Not to mean that they're an excuse to allow problem behavior, but things we want to consider when we're assessing and treating these socially significant target behaviors. So why is your child engaging in any range of these problem behaviors? If possible medical problems have been ruled out, then these are the most common factors that might be influencing it based on, again, lots of research looking at ABA and trying to identify the reasons why problem behaviors happen. The first being that it's a means of getting attention. It's how some individuals have learned to get that reaction or get attention from a caregiver. It may be to get access to a preferred item or an activity, get out of doing something they don't want to do. They may get some sort of stealth stimulation from it. It may be because they're anxious or nervous or overstimulated, or it may be because it's the only way they have to communicate any one of these number of things. So I said I was going to talk a little bit about what reinforcement is. And reinforcement is basically that we all learn to engage in certain behaviors that get us things that we like or remove us from things that we don't like. When this happens, we tend to engage in that behavior more often. So when we talk about things being a reinforcer, it's something that when you get it or when you get out of it, you're going to engage in that behavior that got you there more often. So some examples, generally speaking, are things like getting an allowance. If you earn an allowance for doing your chores and you like getting money, you're more likely to do your chores more often or more quickly if it means you're going to get more money. Anything related to treats and food, for most people, specific what that is, if something you do results in you getting a treat, you're going to do that again. In terms of negative reinforcement, and I should say here, when we say things like positive reinforcement and negative reinforcement, I don't want you to think about that as being good and bad, but more in mathematical terms, in terms of adding something being positive or removing something or subtracting something as being negative. So if you, in terms of negative reinforcement, if you complete something at work and your boss says, oh great, you did that fast, you can take a break now, you're more likely to work as fast as you did before if it means you're going to get more breaks. If that is something that you like getting a break from work, that is something that is reinforcing to you in the context of being negative reinforcement. Work is removed because you completed everything before that. Turning off the alarm clock is another one. It's generally a pretty awful sound, at least my alarm clock is, and it's negatively reinforcing to turn that off. When the sound goes away, I am more likely to turn my alarm clock off more quickly each time it goes off. The most important thing when you're thinking about reinforcement is that there may be a difference between what you think is reinforcing and what your child finds reinforcing. So we can't assume that just because you think, oh, well, this would make me want to do this again, that that's the same for your child or for anyone else in the room for that matter. So there's reinforcement, but then on the flip side, there is also punishment. So for the same reasons, we all learned that engaging in certain behaviors may result in something negative or the removal of something positive. So when that happens, we're generally going to be less likely to engage in that behavior again, to avoid that potential consequence. So the best example here, and again, when we're thinking about positive and negative, that's not good and bad, that's adding something or removing something. So the most frequent example of positive, what we would call positive punishment, for myself especially, if I do something and I get reprimanded by my boss, I don't like being reprimanded. So I am much more likely to not engage in the behavior that got me reprimanded because I find that punishing. But that's not to say that everyone finds that punishing, and that's going to come into play as we keep talking today. So there is still that difference between what we think is punishing and what your child might find punishing. So why does this all matter? We need to understand why the behavior is happening so that we don't make accidental mistakes. So going off of what I just said about the idea of being reprimanded as punishing to me, one example might be that if you yell at your child, it might make the behavior worse because that child just wants your reaction. So yelling at them is not punishing, it's in fact reinforcing because they like getting that reaction, so they're gonna keep engaging in the behavior that got that reaction from you. Another example, a common one that happens at schools, is if a child comes into a classroom and they flip over a table and the teacher sends them out of the class, goes to the principal's office, goes sits out in the hallway, that might make the behavior worse because they may have flipped over that table because they didn't want to do their work. What did they get to do when they get sent out of the class? Not do their work. So what the teacher thinks is punishing by saying, nope, get out of the classroom, is actually reinforcing because it's increasing the likelihood that that child's going to come in and flip the table over right away the next day because it means I don't have to do my work again. Does anyone have questions about those basic strategies right now? We're going to talk a little bit more in detail, but I see a lot of nodding heads, so I'm hoping this is sort of starting to make sense a little bit. Okay. All right, I'm going to let Julia take over.
Okay, so we're going to talk a little bit more about function of behaviors and why that's so important. As Isla's talked a lot about, we use strategies of ABA. Many of you have probably heard the terminology of ABA and you think, oh, that's what the families of kids with autism do. But we're here to say, no, that's not it. ABA is a much bigger picture. It is much more about applying the skill set and the theories of behavior analysis to any problem behavior, whether it's with kids or animals or adults or babies or whoever. It can be applied to anybody. The autism programs have really taken it on as their thing because it's now getting covered by insurance. So they kind of take it on and that's what we do, but you have to have that diagnosis. It's not. So you don't have to have an autism diagnosis to use ABA theories and principles. It's really important to start looking at functions of behaviors because oftentimes families have already tried different services when they've come to our clinic. They've tried different behavior plans and they'll come in and say, that token system never works. Well, it's most likely the fact that they didn't know the right function of behavior. So we're going to go back to saying, you know what, we're going to take a slow approach. We're going to do a lot of assessment first before we start giving you treatment strategies that might not work for your child. Without knowing the function, we're going to get it wrong. We won't get it right, for sure. So the function is allowing us to develop some hypotheses about why we think these behaviors are ongoing. It really then allows us to develop a treatment strategy to directly relate it to the function of the behavior that we found. So first we're going to start off by really clearly defining a behavior. So anybody have an example of a behavior that you'd like to see changed in your kid? Yeah. Awesome. So we're going to use dropping to the floor when he doesn't get his way as our example throughout for a little bit. So I'll probably keep popping back in and asking questions. So dropping to the ground. So what does that entail? It entails a flop from standing position to seated. We're going to clearly define it so that you take data on it, I take data on it, the teacher takes data on it. We all are talking about the exact same thing. So just sitting in his chair isn't going to count, but they actually have to drop. So we have to clearly define it so we can measure it. And we are going to be people that like data, and you'll see graphs and all that jazz. So we need it clearly defined so we can have good, accurate data to really evaluate and know that long term we've made a change. Another precise definition might be of self-injury, hand biting. We might get even more precise by saying biting from the wrist up to the fingernail, or we might have biting where it's just from the knuckle and on up, depending on your child and depending on the topography that your child is presenting with. We're going to measure this behavior. So we're going to have some data sheets. We're going to take data. We're going to ask you to take data. There's a variety of ways we can do this, and we can set up different strategies. This is just a little scatter plot of data. We're doing some tally marks so the time is listed in the left-hand column. The next two columns are tally marks of just a frequency count. And the last column is just an occurrence, non-occurrence. Did the behavior happen during that interval or did it not? So that's a pretty global type of measure, whereas the other two are much more precise. In the first two, the SIB and the banging behaviors, we could then have responses per minute, responses per hour, so we're getting very precise about the behavior so we can evaluate it. The screaming, we're more likely then to say that it's happening 75% of the intervals that are in this particular data set. So 3 out of 4. ABC data is more what Isla was talking about a little bit ago, about those antecedents, behaviors, and consequences. Antecedents, we try to be as specific as we can. We're going to put our date, the antecedent maybe that the child was told they're not going to be able to go outside. The behavior was their temper tantrum, which we then measured how long it happened for 8 minutes. And the consequence, what did we do? What did the teacher do? What did the babysitter do? They provided a reprimand. Don't do that. Be quiet. Shh, you don't want to be so loud. That type of thing. Or they were allowed to go back outside, or everything happened. On 7-6, we had the child was prompted to go upstairs to take a bath. Behaviors that occurred, finger biting, screaming, and running away, followed by being told, don't do that, you're going to hurt yourself, and they didn't have to take the bath. So not only did they get attention in the form of a reprimand, they also escaped taking their bath. You mentioned about dropping in the community. What typically happens after your child's dropped?
Well, I'm working on not reacting.
Oh, good for you. It's hard, and we'll talk about some strategies there.
Drops from 40 to 100 pounds, and he has to scream afterwards, and I'm in the middle of the park, and everybody's
Oh, yeah.
watching. And my latest strategy is to walk away or supermarket.
Yeah.
Walk away to see him, knowing that I'm trying not to react, and he waits, keeps screaming again. And lately, he's starting to get up, eventually, but it's taking so long.
It's taking long. So what you'll see is if you were to continue taking data and continue with your strategy of kind of walking away, not providing any attention, initially what we have is an extinction burst, behavior gets worse, and then it starts to come down when he realizes he's not getting access to those other things that he really, really wants. He wants you to come and attend. He might want a preferred item. Not sure what else he might want, but those are some things. So you're doing the exact right thing, so good for you. But it might get worse before it gets better. Because it worked in the past, right? It worked before, so now when you try a new strategy, he needs to test out if it's going to work again. So to get a little bit more fine-grained about our analysis and trying to identify the function, we conduct behavioral assessments and functional assessments, which is a widely researched approach to assessing problem behaviors. There is a lot of data from 1982 and beyond that has identified that conducting functional assessments, and in particular functional analyses, can lead you to effective treatment strategies. These allow us to evaluate the different levels of problem behavior across different types of conditions. One condition might be a very typical strategy of attention. We look at an attention condition in which, in our situation, we isolate each variable separately. In our padded session rooms, as Scott mentioned so nicely, we have, yes, blue padded rooms, and our one-way mirrors. We have 2 people collecting data on the other side so that they're not involved in the session room, but the child and a therapist or a parent are. And in an attention condition, we evaluate whether it's the child engaging in behavior to gain access to the adult attention. So no other attention is given during that session. The child has some toys to play with, but attention is only given contingent on problem behavior. This is not what we're telling people to do. This is our assessment process. And that just allows us to know, is attention really a factor that's involved? In an escape condition, this is where we're evaluating whether demands might be the problem situation. So in that situation, the child's doing some either schoolwork or doing some daily living skills that you might find challenging at home. And we're going to evaluate whether the child engages in problem behavior in order to get out of doing that demand. So that session looks more like asking the child, put your sock on. Child has a problem behavior, and we say, oh, you don't have to do it then. And we give them a 30-second break. Again, this is just for us to evaluate if that's a factor. We're not asking anybody to do that, and don't go home and do that. The alone condition is exactly what it sounds like. The child's alone in this therapy room. And here we're really looking to evaluate, is this more of an internally driven behavior that happens regardless of environmental situations that are ongoing? I'm going to skip and go to the tangible items. This could be preferred toys or food items. And here it would be, is the child engaging in behavior to gain access to one of those items back? And the last one is toy play. Toy play is what we call a control condition. It's kind of nirvana. They have preferred toys with them. They've got adult attention. And we're looking to see, do they still have problem behaviors in that situation? Because hopefully that would be a situation where there would be low levels of problem behavior. And how we interpret functional analysis results is to compare each of the conditions to each other. So we compare toy play to alone, the behaviors in toy play versus the demand or escape condition. And we look for those to differentiate from one another so they're not overlapping data sets. So here's one example, and this just doesn't happen. Once in a blue moon this might show up in your doorstep, but very infrequently. This is a very clear, does this have, it doesn't have a pointer, does it? Which one's that?
Is it that?
Oh, there we go. Okay, so this line up here is for the attention. And this graph along the y-axis is how many times per minute a behavior occurred. So let's just say it's dropping to the ground. So this one would suggest that about an average of 10 per minute is happening. These are the sessions along the x-axis. We have demand, attention, different symbols. Demand, toy play, tangible along the bottom. No behaviors that happened in any of those other conditions. So we would say at this point, it's clearly that the child's engaging in problem behavior in order to gain access to adult attention. So they're flopping to the ground just to get that attention. This one is much more typical in our clinic, where there's not really good differentiation at all. So here we have behaviors across the attention, the tangible, as well as the escape condition. Although toy play is still low, which is nice because that means at least in the toy play where he has access to everything, it's still good. So this could suggest a couple of different things. There could be multiply maintained behavior, or we just need to carry the assessment out longer to see if it differentiates better. And then this one, this is high behavior across all conditions. High rates across all conditions typically lead us to a suggestion that it might be more automatically maintained or sensory input driven. The child's engaging in those behaviors to give themselves some internal physiological reinforcement. You're going to have to tell me where I'm supposed to stop. So if the hypothesis is this last one where it's more automatically maintained, where it's much more the case that there are environmental stimuli that are maintaining that problem behavior, we're going to think about a few different questions. Could it just be that the child is bored and needs other activities, needs more stimulation across their environment, across their day? Maybe they need activities changed more frequently. Oftentimes we'll see that at school where they're doing the same activity or the same desk work on and on and on, and they have higher rates of behavior. Well, maybe we need to change up their activities every 10 or 15 minutes. Does the behavior occur when the child's alone? If the behavior occurs when the child's alone, it's more likely the case that it's much more internally driven, more physiological. Does the child seem to enjoy or gain pleasure from this behavior? And does the behavior occur even in the presence of toys? Again, that automatically driven behavior is something uniquely different from some of the ones that have more social consequences. So this is just a diagram of the cycle of sensory reinforcement. If you have a child who engages in self-injury and they're getting this sensory stimulation, that sensory input, maybe it's head banging, it's just that sensory input in and of itself that's reinforcing for the child. They enjoy that. That behavior is going to be maintained because they're getting the reinforcement every time they hit their head. And that's just going to continue in this cycle. Now, if your hypothesis is that the behavior may be to gain access to attention, these are some of the questions you're thinking about. Does the behavior get a response from someone? When you're in the environment, when they drop to the ground, are people attending? Are people saying, oh my gosh, why is he doing that? You may not even direct your response to the child, but everybody's talking about it around the child. They're listening, they're hearing, they like that, right? Does the individual try to use this behavior to get attention? Do you see your child go like this and look right at you, like they were looking to make sure you're responding to them. Do people reprimand the individual? Does the individual engage in these behaviors? So somebody else is going to come over. So perhaps you're no longer sitting with them at the dinner table, you've gone to the kitchen, they start engaging in a self-injurious behavior, and you come back over. So did they do it to get you to come back? And does the behavior occur when you are already attending to others? I think a common one that I hear is families, as soon as you pick up the telephone at your house, that's when the behaviors happen. Yeah, your attention just got divided by whoever else is on that phone. You are now valuable. Your attention didn't matter before. It matters right this minute because you're on the phone. Similarly, gaining access to preferred items is much more similar to the attention situation. The child's doing it to get back their toy. They would like to get an item back from you. You took something away, they have the behavior like, oh, okay, stop, don't do it, here, have it. Does the behavior happen when the individual wants you to get him or her something? Like they've decided that they want that cookie now, they didn't want it 2 minutes ago, they want it right now, and they have a behavior to gain access to it. And this is the cycle for both of those types of reinforcement. The problem behavior happens, they either get the attention or they get the preferred item. That increases the likelihood that that problem behavior occurs again because they got the reinforcer they were looking for. And so this cycle continues. Negative reinforcement is a little bit different, and this is a situation where it might be that the child's engaging the behavior to escape or to get away from doing something. So, does the behavior happen when the individual's asked to do something? Okay, it's time to take your bath. That's when they have their tantrum and they don't have to go take their bath, or they delay their bedtime longer. That might be the situation where they're engaging in the behavior to escape or to get out of doing what you want them to do. And this is that cycle of reinforcement. They escape, they get that negative reinforcement, and that behavior continues to increase. Your turn, right? Okay, so now Isla's going to talk more about different treatment options that are associated with each of the different types of reinforcements.
All right, so now what? Now we have our hypotheses based on either some data from a functional analysis or from some other form of functional behavioral assessment that you have helped collect at home or in the natural environment. You've asked yourself some of those questions based on the hypothesis to sort of say, yes, I think this really is what's going on, or yes, I think it's all of these things that are going on. So now we need to figure out how are we going to intervene, how are we going to treat these problem behaviors based on the hypotheses and the data that we have. And there are a few different things that we're going to talk about today, looking at behavioral treatment, some ideas about protective equipment, medication options, and then how we perceive the combination of all of these options together. So in terms of behavioral treatments, which is the primary focus of what we do at the Kennedy Krieger Institute at the MBU, we use the results of those functional assessments to develop, again, individualized function-based treatments. So we want to avoid those mistakes where we're telling you to reprimand your child when they do something because now we know, oh, they do that behavior because they want to get reprimanded. So we need to figure out how do we treat that function, attention-based, attention-maintained problem behavior. Again, back to what I said at the very beginning about why this also takes a lot of time, is that we generally start evaluating one component at a time. And we want to only add new components once we know that that is being effective, once the behaviors have stabilized. And we'll change that if we see no or little effect. If we throw a bunch of things all at you at once and it doesn't work, we don't know what didn't work and what did. And also, we might need to just introduce one thing and that works, and that's the simplest option. You know, we're going to be asking you as caregivers to change your behavior with the goal of changing your child's behavior. So the easier we can make it on you, the better is how we sort of interpret it, and I'm assuming all of you would as well. So similar to the goals of the target behaviors, we want to look at treatment goals that are relevant to you and based on what you think is important for your child. And generally that's going to be increasing some sort of appropriate behavior, which also means strengthening the absence of that target problem behavior. We're going to look at teaching and reinforcing appropriate replacement or alternative behaviors, and possibly doing some other things that might include increasing the availability of other preferred items or other things that we've identified as reinforcing that are going to increase increase the behavior that we want to increase, or things like improving academic compliance. And when it really comes to treatment goals, there are things, so if one of your goals is to increase teeth brushing, depending on your child's ability or strengths and weaknesses, that may be you just want your child to tolerate you brushing their teeth without engaging in problem behavior. But then for other children, it might be like, no, they have the means to be able to assist in brushing their teeth or brush their teeth independently. So this is where it's really important to look, for you guys to look at what are my goals. Just saying I want my child to brush their teeth can mean so many different things that we aren't going to be able to identify for you. We'll work with you to help identify how we want to approach that treatment goal, what's feasible, what are our initial steps. But these are things that are going to be really important to you that we want to focus on when we're going into treatment evaluations as well. So one thing that we often do, and sometimes we do this before we start that functional assessment piece, is doing what we call a preference assessment to identify preferred items, whether they be toys, whether they be food, that may serve in that role as a reinforcer, as something that's going to help increase the likelihood that that child will engage in a behavior to access it. We generally try to use reinforcers for those positive behaviors now. So we want to flip the switch of reinforcers being accessed by engaging in problem behavior to the child then accessing that reinforcer for engaging in an inappropriate replacement alternative behavior. Hopefully this also limits the need for us to use any sort of punishment procedures, like I mentioned before, things that might be more aversive or negative in the bad sense, not negative in the removal sense, because we want to try and teach kids that they want to increase other behaviors that will also decrease the problem behavior. And I'll talk a little bit more about that in a minute too. So the procedures for preference assessment can be very structured, but they can also be very easy for you guys to try things at home. It's basically just identifying whether your kid approaches or plays with an item or consumes a food item when it's compared to something else. So one way might be we might just ask you, what do you think your child's preferences are? And that helps us generate a list, or asking your child. Scott gave a good example of a mini preference assessment of asking Wendy what color of shirt she wanted to wear that day. Yeah, she preferred to wear the pink shirt that day. Might not be related to behavior, but that's still indicating a preference. So one way to, again, more structurally assess preferences would be to do what we call a paired choice preference assessment, and I'll show some data, an example of that in a minute, where you literally present 2 items to a child in pairs and say, which one do you want? And you keep track of which item the child picks. And you might have 5 items and you just pair them each together, and that's going to give you a hierarchy that looks something like this. And this can sometimes be really surprising. When we talk to parents and we ask them, what does your child like to do? What do they prefer to play with? And they give us a list. It's great. That's a great starting point. We have a list of items based on other things they might say. We're like, oh, why don't we try a toy that lights up? Because you said they like to look at the stoplights in the car, and identify some of those things. And then we take the time to present each item paired with the other one to the child, and we keep track of which one they choose. Sometimes it's surprising which items the child actually chooses to play with when that option is there. And this could, again, be something that you try at home just briefly, giving more choices and seeing if that can help decrease some problem behavior in and of itself. Another way is just to literally let a child choose from an array. Put a bunch of items out there and say, which one do you want to play with, and see which ones they gravitate to. Letting the child do a lot of that choosing themselves often provides a lot of valuable information as to how we can use those items, those toys or activities as possible reinforcers moving forward. Now I want to talk about some common treatment components that we evaluate often in our clinic and generally recommend to a lot of parents depending on the presentation of the problem behavior. So I'm going to go through each of these. The first being what you mentioned earlier in terms of what we call extinction or planned ignoring, and that's removal of that reaction that often is being given for a problem behavior. So this can generally be easier if we have hypotheses that a problem behavior is maintained by those social consequences, so relative to the people around them, giving attention, giving items, letting them get out of doing something they want to do. So extinction or planned ignoring is going to be that we just no longer provide that attention. We no longer provide access to that item, and we no longer let them get out of doing what they want to do. This can be more complicated when treating problem behavior maintained by sensory reinforcement, because that's something that's internally driven. They're getting something out of it that is unrelated to what we do. So here's where we might block the behavior or use protective equipment, which I'll talk about in a minute. But it's also can be very difficult to implement true ignoring of a problem behavior, even if it's maintained by social consequences, depending on what that behavior is. So I am by no means telling you that if your child goes home and is about to jump down the stairs as a problem behavior, that you ignore that. But I am saying that you try to block that behavior to keep them safe, but maybe limit the other reaction that you give them, and that you don't then go ahead and give them the iPad, or that if they're doing it to get away from brushing your teeth, that you say, okay, you don't have to brush your teeth anymore. You stop them from engaging in the behavior, but continue with what you were doing beforehand and limit any sort of other reaction that you give them. Again, depending on what that data from the assessment might have told us.
Before you go on, the idea of this planned ignoring or extinction, it sounds so simple, just don't attend to that behavior. It is the hardest thing on earth to ever do. So what I talk to parents about is find something that can compete for you so that you're not attending to them and you're not providing that verbal attention. I had one mom who I worked with, and I've worked with her for many years, and the one thing she did in her home environment, because he was having these really, really challenging temper tantrums, when he would start having a temper tantrum, she would get out her vacuum and vacuum because it overshadowed the noise that he was making having a temper tantrum. She knew he was perfectly safe. He was right there in her visual field, so she knew he was safe. So when I would go and do a home visit, she'd be like, oh, don't you see how clean my house is? I'm like, great, you've had a really bad week, awesome. But it gave me an idea of, she really used that because it was her way of being able to deal with the fact that he was still having this temper tantrum for 10 minutes and it was still going on. But finding something else to do. Other moms I've had, start listening to their book on tape or whatever, or put their headphones in and they block it out. If you can block out the noise, it helps to be able to extinguish or ignore the behavior. But it's really hard to do.
And I think that goes to the point you were bringing up earlier about, and I think Julia mentioned too, the idea of what we call an extinction burst. So if, potentially for years, dropping has gotten a response out of you when he drops in the community, and that's worked for him, he gets reprimanded, or maybe he gets something he wants, or you say, okay, we're not gonna go shopping anymore, we can leave. He's used to that being the relationship between his behavior and that consequence. And then now you're saying, nope, I'm going to follow through with this. I'm going to wait you out until you get up. He's going to say, what is going on? You have just changed everything I've known for however many years, and he's going to maybe fight harder or longer or scream louder. And that's what we call that extinction burst, that it's going to get worse before it gets better. To use Scott and Jennifer as an example again, working on sleeping issues. I've had to have that conversation with them a lot because there are certain things where I'm saying, I know I'm not the one there dealing with it, but this is what I think needs to happen, and it is going to get worse before it gets better. And that happened, but it's getting better now, and that's the part. Thanks, Scott, for the double thumbs up. It is getting better now. I know it was a rough few weeks, and I know I wasn't the one dealing with it, but they stuck strong to what we've talked about. They understood the rationale behind it, and they were committed to making that change. What is also really, really important when it comes to things like extinction and planned ignoring, if you guys are thinking right now, okay, I'm going to go home and I'm going to do this, you really have to commit to it and or make a really firm decision as to what is going to be able to be ignored and what is not. So if your child is dropped in a store and is sitting there and screaming and you're like, okay, this sucks, but I'm going to not respond, I'm not going to give in, I'm going to wait him out, and then we're going to get up. And then he goes to pull down a shelf of food, and you go, oh my God, stop! Now he got your reaction for something way worse than just dropping. And unfortunately, that might mean that now the next time he drops, it's not gonna be a 10-minute tantrum, it's gonna be a drop right next to a shelf where he can immediately try and pull it down. And so those are those things, and I'm sorry for just now using you as a big example, but those are the things where you want to think about what's going on in the environment. So you're going to become a mini behavior analyst on your own. What's going on in the environment? I'd hate to say it, but you want to think, what could he possibly do? What could happen next? So that if you see that happening, you can not just ignore him going to pull down the shelf, but you can position yourself to block it so he can't get at it while still not telling him anything, not reprimanding him, not giving in. this is a really hard example because when you're in the community, it's the hardest of all, and I'll talk about that when I talk about Wendy's data too. But those are things you want to think about, or even at home. If teeth brushing is something that evokes a big tantrum, and you're like, nope, I'm going to stand here, and I'm going to wait, and we're going to do this, and then he goes to jump down a flight of stairs, and you say, oh my God, stop. You know, you've just potentially increased the likelihood that he is going to go jump down those stairs right away if he knows that gets him out of doing it. So those are things where, you know, these are general treatment components, but they're things that you want to be looking at and evaluating with a professional very carefully and very systematically, because we don't want an extinction burst or that implementing the planned ignoring to lead to more problem behavior or something that's increasingly dangerous. Does that make sense? Does that seem like, have you guys had those thoughts, or is that something that you may have experienced in the community with your son if he's up in the ante now and you're like, okay, can't say that, and having to be really careful?
Well, and I will share that one of the things we do for our families is we have parent concern cards that we give to families, and it basically says, hey, I'm getting treatment at Kennedy Krieger by so-and-so. If you have questions, feel free to call them. It has our inpatient number and our outpatient number. Families, we've never gotten calls from anybody. We've given out thousands of these cards. So having a little thing that says, I'm being treated by a professional, does help other people go away if you want to have people leave you.
So again, sort of briefly summarizing everything I just talked about, we want to do the opposite of what the child wants through their behavior, what they've currently and been doing possibly for some time. So they want to get a reaction from you, you ignore that, or again, block and ignore that behavior. They want to get out of doing something, you ignore the behavior, and you keep going with whatever that task on the schedule is, or whatever that demand that you've given them. And we're going to talk more about some strategies to help you do that right here, actually. So one thing we often recommend, and again, recommend also means that we practice and we try it out, we assess and we evaluate it, is using a consistent prompting sequence whenever you ask your child to complete a task. This not only helps your child understand what you're expecting from them or what you're asking from them, but also helps you stick with not allowing them to get out of doing that task. So something called 3-step prompting is a commonly used prompting hierarchy, and we use that a lot at the MBU. And that involves using a least to most invasive methods for following through on a demand. And what I mean by that is we're going to start with something that is very easy, doesn't invade their personal space at all, and increase that across 3 steps. So the first step being a verbal prompt. You tell your child what you want them to do. You wait, are they going to do it? If they have problem behavior, you're going to ignore that and you're going to keep going with the prompting sequence. If they do it, great job, provide a lot of praise. If they don't do it, you're going to go on to what we call a model prompt or a gestural prompt. And this is where, again, we're looking at helping your child understand what the expectation is. So if my initial prompt is to say something very basic, touch your nose, you know, your child might not know what I'm asking you, but they are wanting to comply, but they don't know how. And so I'm going to provide a model prompt to say, touch your nose like this, like what I'm doing. This is what I'm asking you to do and what I'm telling you to do. If they have problem behavior, I'm going to block or ignore that and continue on with then physically guiding their hand, taking their hand to say, this is touching your nose. So I'm getting that compliance even though I'm having to physically guide them to do that. Now, this is important, again, when it comes to, and I use teeth brushing a lot as an example, in terms of, again, what are your child's abilities, what can they do and what can't they do, where do they struggle? You know, saying something like, go brush your teeth is a very big demand for some kids. And also then, if you're thinking in your head, okay, I just said go brush your teeth, now I have to say, okay, go brush your teeth like this, and go through all the steps of modeling what teeth brushing is, as opposed to thinking, okay, let's break this down a lot. All right, go stand by the sink. Great job. Pick up your toothbrush. Pick up your toothbrush like this. And going through and you're showing the child, this is what I expect from you when we're talking about brushing your teeth. Again, this is something, maybe certain things you feel like, oh, I could do that at home on my own for some tasks, but also might be something you, again, want to go seek a professional's help in terms of getting some structure and assessing if this is really something that I can do. You know, and going back to your example of dropping, I think you said your child weighs about 100 pounds. So here's another example where you want to be careful what you're prompting. If you've evaluated it and you're saying, okay, I'm going to follow through with this prompt. Well, full physically a prompt of stand up can be difficult to do. And so there's some, again, things you want to be talking with a professional about. What do I do? Do I wait it out? Do I keep prompting them? And that's something that, we can't answer right now for certain cases, because it'll depend on what that motivation is, what the assessment has said, and what's safe to do in the community. Oops. So another thing that we've talked about, again, reinforcement is obviously a big word in what we do in ABA in general, is we want to look at differential reinforcement. And there's a couple different ways that I'm going to talk about using that today. But basically, we're looking at reducing those inappropriate problem behaviors by structuring, adding that reinforcement for some other or alternative behavior. So when we're talking about differential reinforcement of an alternative behavior, or a DRA, we have identified exactly that, an alternative behavior that can replace that undesirable behavior, and we're going to reinforce that instead. So if we're ignoring problem behavior because the child wants attention or food or toys, then we're going to find a way to reinforce them with those items, if that's what we've identified as the maintaining function, for more appropriate behavior. We want to always use that functional reinforcer. If a kid is having problem behavior because they want an iPad, we don't want to necessarily just give them attention for something good if what they still want is the iPad. We want to find a way to get them to what they really want by using an appropriate behavior. So basically, overall, this is going to teach the child that the way they get things is through some alternative appropriate behavior instead of just having that problem behavior. Another way to look at differential reinforcement is what we call a DRO, or differential reinforcement of other behavior. And what this basically means is just we're going to provide reinforcement for the absence of the problem behavior. So they don't necessarily have to do anything instead of the problem behavior, they're just not having the problem behavior. So something like a DRO is going to be based on time. So we might say, all right, if they go 10 minutes without any problem behavior, we're going to reinforce them with something that we know is they're motivated by, whether that be playing a game with a caregiver, whether it be 5 minutes with their iPad, whether it be a small snack. So it's based on just a time without problem behavior, and not necessarily the child exhibiting something specific in replacement of that. Now again, when we're thinking about this, and going back to that very first slide where I said treatment takes time, when we approach implementing a DRO for a child, we generally start very small. We're going to look at things like, can a child go 5 or 10 seconds without problem behavior to access that reinforcement, and slowly but surely and very systematically increase that time to a goal that is, again, socially significant to you. And this is where sometimes it's going to be a conversation with your professional that you're working with. Is it reasonable to say your child can go a whole hour without engaging any problem behavior to access attention? Maybe, maybe not. Maybe 15 to 20 minutes is a much more reasonable goal, and that's something that we need to talk about with you in terms of your schedule and your lifestyle, and also what we see with your child's problem behavior and what's going to be realistic for them. Another thing that we talk about a lot is what we call non-contingent reinforcement, or NCR. And that's just where we give access to these preferred things for free. It's not based on time. It's not necessarily based on an alternative appropriate behavior. It's just that we know now that your child likes these certain things. They like to get attention, or they like to get time on their iPad. And we just say, all right, we're going to give this away for free. We're going to catch them being good and just say, hey, you're doing a great job right now. I love how you're sitting there quietly and playing with your toys, so that they're always accessing that functional reinforcer. So the motivation to get it some other way that they've done forever in terms of dropping or self-injury isn't going to be there. We've kept that tank full. If they're really motivated for your attention and we're just providing it to them all the time for free, then hopefully they have no reason to want to bite their hand or drop to the ground to get it some other way. So then we talk about those behaviors that are maintained by, I know we've used a lot of different terms, but by automatic reinforcement, or self-stimulatory, or internally driven physiological consequences. And how we try to approach this, and this is certainly one of the more challenging types of behavior, because again, we can't control how they're feeling that internally, but we try. And we do that by trying to increase that sensory reinforcement in some other way, whether it be specific in terms of if we feel that it's because they get to chew on something, that's the input that they want, or whether it's just a general sort of sensory reinforcement that we need to add more stimulating activities to their environment, or giving them more hugs, more of those other sorts of sensory things that have been identified as preferred. Generally, we are always going to recommend that you do your best to block and ignore those behaviors, and that's sometimes easier said than done. And possibly we are going to look at teaching alternative skills, even if it's not something directly related to the reasons why we think the problem behavior happening, but because it's a good socially appropriate skill to have. We've talked about extinction in terms of you guys ignoring and removing your response or not letting a child get out of doing what they want to do, but that doesn't really come into play when we're talking about that internally motivated type of behavior. So there's where we look at sensory extinction. So we try to, if you can, think about it, find a way to ignore that behavior happening internally. So we don't allow the behavior to get to that sensory input. Generally, this is going to involve the use of some sort of helmet or some sort of protective equipment. If a child is hitting themselves in the head, and we find that to be because they get something out of that, if we put a helmet on, a padded helmet, they're still engaging in that same behavior, but the helmet is stopping them from getting that sensory input. Again, I'm going to talk more about that, but that's something you want to be very careful with and evaluate very closely with a professional. So when we talk about teaching appropriate replacement behaviors, specific to those that may be maintained or mostly maintained by access to attention, one of the most common strategy, and you'll see a theme here, is what we call functional communication training, or FCT. As Scott mentioned, communication abilities vary greatly for kids with 1P36, but we can always try and train some sort of response or modality for communicating. That might be exchanging a picture, that might be their own vocal output, or some sort of communication device, or some combination of all of the above, but teaching a child a replacement behavior to ask for attention as opposed to engaging in problem behavior to get that attention. Similarly, for behaviors that we find are maintained by getting access to preferred items or activities, we might also use some FCT to teach them to appropriately request for those items, but that might also mean we have to teach them about schedules or pictures of when items are and are not available. Just because you can ask for an iPad doesn't mean you actually can get it every single time that you ask. So that might be teaching a child to tolerate periods where you can't have access to the iPad, or that you get it for much shorter periods of time, or that the iPad's just not available at school all day, you can have it when you get home. And then also using maybe those results of a preference assessment to identify other alternatives. So maybe it's not the most preferred item, but maybe there is something that they're like, oh, they like this sometimes, I can offer this, or give them a choice to play with this as an alternative. And then we also look at those escape maintain problem behaviors. So those behaviors that kids engage into to get out of doing something they don't want to do. Again, first and foremost, we want to find some way for you as caregivers to help them follow through with that demand, not let them get out of doing it. Additionally, though, again, we might use some sort of FCT, that functional communication training, to teach them to ask for a break or ask for help if they need it, if they aren't sure what you're asking them to do. Other things might just be providing frequent breaks in that non-contingent way for free. You get a break for free after you do a certain number of things, or overall just general compliance. If you've done 10 things, you get a reward. So what do we do about those behaviors maintained by automatic or self-stimulatory reinforcement? So here I'm going to show you guys a little bit of Wendy's data from when she was working with us. So we did do a functional analysis with Wendy, looking at the primary concern at the time was her hand biting. And as Scott said, Wendy is very, very smart. And we went into those blue padded rooms and she was like, this is not the real world. I'm going to sit here and never bite my hand again. So we had to get a little bit creative with her and do some home visits and do some sessions outside of the session room. And generally what we found is that for Wendy, her hand biting specifically, and that's just that behavior of hers that we were looking at, was partially maintained by automatic reinforcement. She got something out of it. Also that she did it when she was bored, and that she did it when she was mad, and sometimes she did it to get attention. So it was kind of a little bit of everything. So the first step that we took with that was what's called a competing stimulus assessment. So I'm going to figure out how to use this. So here we wanted to find, looking at a little bit of both that automatic, that sensory reinforcement, but also that I'm bored kind of way. We wanted to identify some items that were appropriate for Wendy to bite on, because we were hypothesizing that that was where that sensory stimulation was coming in, was wanting to bite things. But that also she would sort of play with that might decrease some of the boredom in certain environments. So what this graph is showing us here on the y-axis is the percent of sessions. So this was in our blue padded rooms. We had very controlled data collection happening here. The percent of our session that the red bar is that she was biting that item that's listed here on the bottom. The green is just the percent of the session that she was playing with the item with her hands, not necessarily biting on it. And then the purple bar here is related to this axis over here, the responses per minute of her self-injury. So you can see we evaluated, I think, 7 items, and then we did have a control session. How much is she engaging in her self-injury with nothing there present for her? So what we were looking for here were items where we had high green and or red bars and low purple bars. So she was engaging with the item, she was biting on the item, she was not biting on her hand. And what we found here is we had a few. You know, she had some high rates of her self-injury over here, so we kind of ruled that one out. But we have a few here that look pretty good. And then also what we know about Wendy is that she does like to make choices. She likes to have some control over the situation. So in working with Jennifer and Scott, it was like, all right, so maybe we're going to use a bunch of these items and give her a choice of which one she wants. So what we did next was we went into our treatment evaluation. And I will say we had lots of other things going on with her. This is sort of one primary example of how we were approaching treating some of her problem behaviors. So as Scott and I have both said, Wendy wouldn't be Wendy in our blue padded room. So we had to get creative, and we spent a lot of time outside of our session rooms, walking around the hospital, going to different areas there. And so this is where we collected our baseline data. So this is where I told Jennifer, all right, let's go walking. And we took data on how often was Wendy biting her hand while she and her mom were walking around like they normally would. They'd stop to look at things. We're kind of taking some of this more ABC type data as to what was going on here. So here you can see with this baseline data that Wendy was biting her hand. Again, this is specific to that. Biting her hand between 1 and 2 times per minute while we were doing these sort of walks of varying durations, usually at least 10 minutes each of these data points. So then we did our competing stimulus assessment that I just showed you, and we said, all right, we're going to give Wendy access to this item. Jennifer, your job is to try and block her from biting her hand and redirect her to that item. Make sure she's got that item in her hand, maybe kind of just gesture her hand towards her mouth so we're remembering, trying to teach her, you bite on this instead. And this is what happened when we did that. So down here is her hand biting. So by giving her access to one of these competing items, and we let her choose each time, and if she seemed not interested in one, we give her a choice of another one, she almost totally stopped biting her hand. All of this, everything else was the same. We just, let's walk where we're going to walk. Jennifer, stop when you're going to stop. And we saw a big decrease in her hand biting. This data path up here is just that we wanted to make sure it was actually because she was using the item itself. So this is how much of those sessions was she engaged with the item, either biting it or playing with it, and we saw a lot of progress there. Now going again back to that first slide, I talked about introducing one component at a time. So this really helped with her hand biting initially, but we also wanted to teach some more appropriate skills. What's not shown here is that even when she's not biting her hand, if Jennifer stopped to look at something, Wendy might cry or pull away, things that were still socially significant to her family as being inappropriate. So we wanted to teach Wendy, all right, you can ask to keep walking, and we introduced a very just basic picture card to get some simple responding of, I want to walk some more. And once we did that, things stayed good. She was still not biting her hand, and she's still engaging with the item. We don't have the data to show about the other behaviors, but we wanted to make sure this is still working as we add these things in. The crying and the other behaviors seem to stop. And so then we went into what we sort of call more of a generalization. Is this going to work for longer periods of time? Increased stopping and waiting. We're like, all right, now you're going to wait for 5 minutes. Adding in, well, you can't ask to keep walking right now. You have to wait. And so we evaluated all of that over multiple sessions and things still look good. She wasn't biting her hand. She wasn't crying as much anymore. Things were much more feasible for Jennifer to be able to walk with her out in the community. And that's also when we started to do some more home visits and going to more environments that are natural and close to her home. So in addition to, like we talked about, these reinforcement strategies, there is this other avenue that we occasionally take that we look at response reduction procedures. And these are these procedures that we would include in the punishment category. So we always try to focus, again, on increasing appropriate behavior that will then replace the problem behavior and automatically reduce it. But sometimes that's not enough. Sometimes that problem behavior isn't reducing, even if we are making improvements and increasing some appropriate behavior. So we need to target that problem behavior even more specifically by adding in something or removing something that is going to decrease it, as opposed to just increasing the problem behavior. So this might be where we try something like a timeout, where we remove items or remove the child from a situation, contingent upon that problem behavior. You know, we really like to use these procedures in very short periods of time, so 30 seconds to a minute. I'm sure many of you have probably heard that rule of timeout should be the number of minutes of your child's age, which we really find that that's not, you have a good example of that.
Well, I'm not sure which example I used when we practice, but one of the things is if we can't tolerate that length of a burst from them, we're never going to keep them in that timeout for the 8 minutes that they currently are old. And so what ends up happening is everybody gets angry, everybody's crying, everybody's having a tantrum. So make it a short amount of time so that the timeout can end and everybody can move back on to their life, because otherwise you're in you get into a vicious cycle of being in timeout forever. I don't remember what example I did, sorry.
And generally, we want to use these in conjunction with the reinforcement-based strategies. We don't want to just say, all right, just do timeout over and over and over again. We want to have in place something where they are able to access those reinforcers that have been identified as part of what's maintaining their problem behavior, but maybe we need this other step in there. The goal should always be for these response reduction procedures to be reduced over time. A lot of the reinforcement-based recommendations we have generally stay in place for a long time. Maybe you don't need to be giving them as frequently. Maybe other skills develop so they're not as relevant. But hopefully these response reduction procedures are a short-term thing. And again, as we say with everything, this is something you wouldn't want to necessarily just go home and try on your own, but you'd want to be talking with a professional about that.
And the other thing with response reduction procedures, if you don't see a pretty quick decrease in the problem behavior, it's not effective, move on.
So sometimes if a behavior is very severe or it persists even throughout a lot of these different procedures, which might include reinforcement-based strategies or response reduction procedures, we may need to try something like protective equipment. This could be in the short term, so if a child is biting their hand and has caused some significant injury, maybe we need to implement something pretty restrictive like arm restraints until the arm heals or until the hand heals. It could also be long term in terms of procedures that are used either contingently on the problem behavior, so maybe a child hits themselves in the head quite hard and we need to put a helmet on right after that, or non-contingently. Maybe in certain instances, going in the car where you can't block a behavior, we have the non-contingent, you put it on no matter what, a helmet's because you want to keep that behavior from happening in the car specifically. So again, some examples might be gloves, helmets, or arm restraints. These should, again, always, always, always be evaluated systematically to determine what is the least invasive, but also therapeutic option. So again, thinking about hand biting, if you put your child in arm restraints or arm immobilizers, they're certainly not able to bite their hand, but they're also not able to feed themselves or scratch an itch on their head. And maybe you need that for a short amount of time, but maybe also you could evaluate, do gloves decrease that hand biting and still allow your child to feed themselves, to really be a more active participant in their community. So this is, again, something where we want to find that least invasive possible option that also helps you see some therapeutic benefit. And then medication is something that we work a lot with psychiatrists at the Kennedy Krieger Institute, and unfortunately, there's no single medication that has been identified to treat self-injury or other forms of problem behavior. The most important thing, if you're thinking about pursuing some sort of medication trial, is to find a psychiatrist to consult with who has experience with treating individuals presenting with problem behavior. There are a lot of medications out there that have shown some effectiveness, but that's going to, again, depend on the individual. How not all children who have self-injury are going to respond to certain medications the same, even if there's research to show they're effective. You want to be working very closely with a psychiatrist who has experience in working with kids with problem behavior. So one of the studies that I think Scott already mentioned, again, this is small sample size, but there they talked about 37% of the participants in that study, I think it was only about 40 individuals, were taking medication to help manage their behavior problems. And here's just some, the average age for when they started taking those medications was between 9 and 11 years old. Again, I think this was the study where we're looking at kids 12 and older, and so I wouldn't be surprised if more information now would show that those average ages were significantly younger for looking at possible medication trials. Generally speaking, the best outcome is going to come with some combination of behavioral treatments and medication trials, possibly protective equipment, but it's all about looking at what is right for your child, what do they need, where are you seeing that progress, what's working for them. So one other consideration is school. You guys are at home with the child and in the community with your child, but that doesn't mean they're not having similar problem behaviors at their school. As Scott said, here in Baltimore, we have the Kennedy Krieger Institute, but you have your school to go to as well. There are going to be individuals there, like a school psychologist or a behavioral resource staff member, who's going to be able to do some of what we've talked about today in terms of conducting a functional behavioral assessment, looking at those ABCs, collecting some of that data to help develop those hypotheses as to why your child might be engaging in problem behavior in the school environment that may also help in determining why your child is engaging in the problem behavior at home and in the community. Once a functional behavioral assessment is conducted, they can generally look at some of these intervention strategies and develop an individualized behavior intervention plan. And these are things that should be reviewed annually at a minimum, and changes should be made based on progress. It is not a one-size-fits-all. It is not if it's working now, it's going to still be working the exact same way in 6 months. They need to be collecting data, looking at that, evaluating that, and you need to be a part of that process as well. And really, you want to be working collaboratively with your school for multiple reasons, because again, if they find something that works at school, maybe that's going to work at home, or vice versa. If you find something that works at home, tell the school and say, hey, this is working for us for compliance, maybe this can work here, work together. Because another thing that we found and the research has shown is that consistency of how you're both responding to behavior and setting up opportunities when behavior occurs can be really vital for continued success. If you guys are working so hard at home to follow through on demands, but every day your child goes to school and they get out of doing work for that problem behavior, that's going to take a toll. You're not going to see that full progress, because every day when they come home from school and all of a sudden they have to be following through on what you've told them to do, you may see an extinction burst over and over and over again, and that's not good for you and it's not good for them. So in conclusion, it is possible to decrease problem behaviors in individuals with 1p36 deletion syndrome. You need to monitor those antecedents and the consequences, the befores and afters surrounding the behavior. Develop some of those hypotheses about why you think the behavior is happening, help start figuring out what the function is, and then work to evaluate some of these strategies to decrease the problem behavior while also increasing appropriate behavior. And again, taking data is the best way to do that, to make sure that it's working. We want to have those recommendations, once they're developed, implemented across caregivers and across contexts, and be persistent and don't give up. Again, everything we've talked about takes time. The Winnickes and I have been working together for over a year. We've met some goals, but we're still targeting some other ones. It takes time to address a lot of these things, and so you need to be persistent and you need to keep going. So here's some recommendations for where to find professional guidance. The Behavior Analyst Certification Board website actually allows you to search for BCBAs, individuals who have specific experience in ABA, so you can find them in your area and just call them and ask them, hey, do you work with kids with severe problem behavior or kids with genetic disorders or developmental disabilities, and see if they're able to help you out. Also looking for licensed psychologists in your area who have experience in the assessment and treatment of problem behavior is a great place to start. And, I'll let you take it.
Okay. So this is our contact information at Kennedy. Both of our email addresses are there. Feel free to contact us at any point, whether it's for contacting us about any clinical questions you have about behaviors you're seeing, or you're looking for advice about somebody in your area or what you're treating in terms of the behaviors your child might be having at this point. Additionally, Isla and I are working on putting together a research proposal that has to go through the Johns Hopkins IRB for approval. But we'd like to really evaluate more closely some of the behavioral presentations of kids with 1P36. It'll probably be most likely a bunch of questionnaires for you guys to fill out and then mail back to us. But I'd love to be able to come back in a couple of years and say, hey, based on all that data you sent us, here's what we see about our kids with 1P36. These are the behaviors you have. These are the treatments that have been working. These are the strategies that can continue to try. That's something we have to get approved through the IRB first. And Hopkins is a long process, sorry. But once we do have that, we'll have a little flyer that we can post on the 1P36 website under their little research page, announcing that people could contact us if they're interested in participating. We'd love to do that. I think it'd be a great opportunity to really get some more information about the behavioral presentations of the kids with this disorder. Oh, and if you have any questions.
And we will also be sending the slides to Jennifer to post online, or if you want to email us directly, we can send them to you as well. Thank you. And yeah, any questions?
I can come around with the microphone if somebody wants to ask questions. I will say this was kind of interesting for me. Some things must be better, because for about 2 months, the most common thing I said is, chew on your banana, chew on the banana, chew on the banana. And I'd even forgotten about this banana toothbrush, which is the thing she used as her other stimulus to not bite her hands. So that must be better. And saying things like, walk is not available. So it brought back kind of some fun memories. We've made a lot of progress.
Hi, you mentioned the ABA and autism connection, and I know at our schools when we were looking to transition our daughter into kindergarten, they were saying, well, we have ABA-only programs that are run for the autistic kids. Do you feel that the IP36 kids would do well in those programs?
So given the nature of what ABA programs are and the fact that they're pretty database and pretty structured, and those are things that all of our kids do really, really well with, structure and activities, it's probably the case that your 1P36 kid would do really well in that environment, because they are geared towards monitoring any of the problems that arise, making sure that the activities are structured and followed through on. So it's probably would be a good situation. It probably would be helpful. He's running.
Just a comment, our son's 16, and as most of us in this room know, we're kind of out there in the middle of nowhere with, unfortunately, a lot of kids with autism because it's so prevalent. But our school district has become very serious about verbal behavior and errorless learning, which is based on the principles of ABA. Mm-hmm. So for the first time, our son has been working with errorless learning, errorless teaching, and ABA principles, and he's 16. So the first time ever at school, there is positive data, because this is all research-based. And I mean, there have been a lot of problems at school. So my point is, if you get the chance of being in a classroom where they're doing ABA, I mean, don't you agree?
Absolutely.
Go for it. It's research-based.
Yeah. I'm going to say,
you know what I mean?
One of the things that families often come to us and ask is, well, won't this diagnosis, won't this help us get things? Well, I'm going to be honest with you. The population of individuals with the autism diagnosis do get a lot more resources allocated to them. Even if I don't think your child may have autism, it might not be a bad school district classification to put them under if it allows them to go into that classroom. It's a classification. It isn't going to make or break them long term, but it will get them access to services that they may or may not be able to get otherwise. And yeah, autism is just the hot word these days.
Hi, my daughter is 16 years old, and when she was very young, she used to bang her head, and that went to hand flapping, and after hand flapping went to spinning. But now she's pulling out her hair, and she has broken off about 30% of her hair. We're very concerned. She does it a lot in her room, so she doesn't always do it where we can stop her from doing it, and she says she can't stop herself from doing it.
Yeah. Can we talk a little bit more? Trichotillomania, which is what that's called in the big words, that they like to use with certain topographies. I've got a couple other treatment strategies, but it's a little bit more than what everybody's heard about so far. I'd like to talk a little bit about her functioning level, her cognitive ability, and things like that, to talk about whether some habit reversal or some covert behavior monitoring might work. I did have a child who one of the things they did is at times when they knew were a high probability that they would do the hair pulling, not easy to get out, but they put Vaseline because they couldn't then grab their hair and pull it out because it made it then an impossible kind of thing. But it was because there were certain times they couldn't monitor like on a school bus. So they would put something in that would make it too greasy for them to pull at, allowed the hair to regrow, and then in the meantime we were teaching some alternative behaviors. But if we can talk some more, I can give some other, we can talk more of specifics.
Okay.
I do want to say, I think that brings up a really good point that we often see as well, that sometimes you may be having a specific problem behavior that you're trying to target through behavioral services, and you make a lot of progress and things are going great, and then all of a sudden something else starts happening and you're like, what? Come on, I just worked so hard for a year on this hand biting and I'm not having to talk about a banana toothbrush anymore. But now it is that we want to target, now her sleep is so disrupted and all of the things she's doing there. So again, that goes to that point again, that it's a long process, and where if you find a professional that you want to work with, your contact with them is probably going to wax and wane over the time that you're targeting some of these behaviors. And it's frustrating because something that you may have spent a lot of time working on and is working really well might not work for this new target behavior that's coming up, and you're feeling like you're starting over again. But the thing that you have to remember is that you're going to have more of this knowledge now in terms of, all right, they've started this new behavior. I'm not going to spend all this time thinking about oh my God, blah, 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 blah. But all right, I know what I can do. I can look at the ABCs. I can see what's going on in the environment, because this is what I had to do before, and that's going to help me start figuring out what might work here, or what I specifically want to talk to the professional that I've been working with about, and say, I've already got some preliminary data to show you. Here's what I think's going on, and that's going to just help speed up that process even more.
Yeah, and I mean, I think you have to remember too, this really gets into the heart of their talk. The reason for the problem behavior might really be important. And with hair pulling, is that boredom? Is it some sort of interesting feeling for them? I mean, I don't think I would like it, but sometimes, that's self-stim. Is it anxiety? Is it, there could be many different reasons. And sometimes it's really hard as the parent to figure those things out, which is why when they measure it in a very controlled way, they can often figure it out, even though maybe it seems obvious in retrospect, but sometimes when you're in the middle of it, it's really hard to sort of figure it out. I think we can take one or two more questions.
I know it's a little controversial, not trying to open a can of worms here, but Charlotte's Web has been newly recognized as helping with behavioral problems. I was wondering how you guys felt about it, if it was some type of medical,
It's like a CBT.
Yeah, I was, because my daughter down in Pittsburgh Children's Hospital, they were offering, saying whenever it becomes legalized for, it's already legalized, it's going through the medical systems right now. They just told me it takes 2 to 3 years for it to become available to children with Zola's types of problems, that it could possibly help her and calm her down. So I was just wondering maybe how, I don't know really what I'm asking.
I don't know what that is.
So we're talking medical marijuana.
CBT, essentially. Well, derivative thereof, but yes.
Yeah. So it hasn't been studied. I mean, I'll be honest. It hasn't been researched and studied to be identified as a procedure or a medication that would be valuable. In Maryland, we cannot use that. We've had a number of, the neurobehavior unit we work on has both an inpatient program as well as outpatient. We both do only the outpatient side. We've had many people trying to come into our inpatient unit, and will only come to their inpatient unit if they're allowed to continue with that treatment, and we're not allowed. It's against the law here for us in Maryland. So families would have to opt out of not doing that anymore. I don't have any particular case examples of families that I know who have been using it where it's been successful, so I can't really speak from that point. I think there need to be research-based studies to have some data to support whether or not it would be valuable. I'm not going to be able to speak directly.
Yeah,
All right, I'm going to do two more questions
I was going to
because
just add one more thing to that,
the
Scott.
child care people will probably want to take a break and get lunch, and we need to eat. But we'll let Isla talk, then we'll do two questions, then we're going to break for lunch.
I think it could possibly even considered similar to any medication. Even if it were to be legal across the board, every child is going to respond differently to that type of treatment, the same way that even some medications that have been shown to be effective for, again, specific parts of target behaviors might not work for your child. It's not 100% guaranteed. And so I think generally speaking, more research is certainly needed to show if there are patterns in terms of how something like that might work for certain kids. I think it's going to be the same as any medication. We would need to try it to see if it works.
Don't push it or.
Go, just talk.
Okay. I was using CBD in Tennessee, which is legal to use for seizures only, so we were using it for seizure control, but accidentally discovered that it stopped all the behavior problems, and so it was, I'm a big believer in it because it stopped all of Hunter's self-abusive behavior.
That's great. We're happy to hear that.
All right, last question.
Totally different. I've got a 23-year-old, and we're talking about behaviors. We are so good when we're out in public, and she wants to go out, and and it's like things are great, and as soon as sometimes we can walk in our house, and it's like, whoa, and it's like do that behavior, and it's like, hey, you're so nice to everybody else, and then when you're people that you love, you know what I mean? But it's like sometimes it's like, how do you stop that? I'm like trying to ignore it, but it's also the physical. You got 300 pounds, and it's like, hey, we're great, but then all of a sudden, wham! As soon as we get in the house, yeah. And I thought. Is there, ignoring it or something, certain things, but it's like all of a sudden you turn off that thing and it's like we want to go out, and then when we come home, no offense, but all hell starts.
Yeah. And I think, again, that's such a hard thing to approach, and we see it all the time. And we saw it with Wendy. Again, she came into our clinic and she didn't do the behavior. And we're like, Jennifer and Scott are saying, we promise this is a problem. We're not lying. And I'm like, I know you're not. I know you're not. And even when we first started to go out into the community and we did see some more behaviors, Jennifer would be like, that's like a 3 out of 10. Like, that's nothing. I'm like, all right, well, then show me. Let's go do this. And I went out to the house and we went to a restaurant, Jennifer and Lexi and Wendy and I. And I think Jennifer still laughs at my face when I was like, oh, okay, I get it now, because Wendy was then showing. She was at like a 7 or an 8. And I was like, all right, got it. I see where we're going here. And it was just that difference of that environment. And that is what's a big challenge about what we do is, for whatever reason, your child loves being out in the community. What is it about at home for however these 23 years that has created these problem behaviors? And that's where, again, you might want to find a professional who's able to come to your home to look at that, because it's likely that if you were to pursue treatment in a clinic setting, you'd be having that same conversation of, I swear this is a problem, I swear this is a problem. If I did this at home, it would be different. Then you need to find someone who's going to say, okay, let me come to your home and let me see what's going to be happening there. And that's a very important question to ask if you are looking for professional treatment. Do you have the ability to come into my home or into my community? Because it's certainly possible that being in the clinic, you're not in a clinic setting, especially a blue sterile room with lawn chairs, is not going to be realistic of what's going on in your home.